Okay, you can probably start, hey? What do you think?
Yeah, I think we can start. Okay, good afternoon, everyone. Thank you for joining. We want to welcome Dr. Martie. She's a pediatric critical care specialist at the Red Cross Children's Hospital, and she will be teaching us, hopefully be able to teach us today on cardiogenic shock in peds. Be attentive and listen carefully because there might be some questions fired at us. Enjoy.
Hi guys, thank you so much for having me today. Can you all hear me well? Like maybe you can just give me a thumbs up or just put out in the chat if you can't hear. But basically, I was asked to talk a little bit about shock in pediatrics and maybe specifically about cardiogenic shock, because I think we often learn a lot about septic shock. But I think cardiogenic shock is quite an important topic, and it's important to recognize it. So they've asked me to talk about that, and if you think about any questions, put it out in the chat. I will be doing some case studies. I know we're all trying to find the best way of doing online teaching, and I'm going to try and keep it as interactive as possible. So please participate. If there's a bit of a question, put out your answers and see if you can give us some clues on the case studies and give your input, because I think that's the best way that we're actually going to learn. So what we'll do today is we'll talk a bit about pathophysiology of shock, and then specifically about cardiogenic shock and recognizing it. We'll talk about how to approach the child with cardiogenic shock and how to try and work out what is going on, and then some basic management principles. Okay, so just looking at what is shock. Okay, so I think shock is when you fail to keep your balance. So it's a failure of the circulatory system specifically. But it is when you can't deliver adequate amounts of oxygen and nutrients to your tissue. Okay, so that's when we start seeing end organ tissue that's not well perfused. And it's also the inadequate removal of waste products. Okay, so if your lactate starts going up, that's normally what we see in shock, and it's really about the imbalance between oxygen delivery and oxygen demand. So your demand is very high, and you don't have enough oxygen delivery to your tissue, so you actually have reduced tissue perfusion that ends up leading to cellular hypoxia and energy failure. Okay, so what happens specifically to the tissue? So I'm sure you guys have heard about the equation of life. So this is really my way of working out a lot of things in the ICU and a lot of treatments for different conditions. As if you know the formula for oxygen delivery, you can normally work it out. So I'm sure a lot of you guys have heard about it and have seen it before. I'm just going to go through it again because that's going to form a lot of basis of my presentation and later on how the different management principles is based on. So I always remember that OD is CO times OC. So oxygen delivery is oxygen content times cardiac output. Okay, so I'm going to go into each of those now. So if we look at oxygen content specifically, that is HB, so your hemoglobin, multiplied by your SATs plus your PaO2. So if you just look at oxygen content, you can actually see, because HB and SATs are multiplied by each other, PaO2, or what the PaO2 on the gas is, actually plays a small role to what your oxygen content is going to be. So if you can get your SATs up and your hemoglobin up, normally that makes a lot of difference in the equation of oxygen delivery and getting your oxygen delivery up. Okay. Now, if we look at cardiac output, we know that cardiac output's formula is heart rate times stroke volume. And heart rate, the important thing about it, it needs to be in synchrony. And stroke volume is related to preload, afterload, and our contractility. And we'll go into more detail about how to optimize all of that so that we can actually get adequate oxygen delivery to our patient. So just again, going into oxygen content, you can see that it is not just about the hemoglobin. It's about how much hemoglobin is carried by oxygen and how much is in the solution. But the solution part plays a little role compared to what the hemoglobin carries, how much oxygen the hemoglobin is carrying. So if we then look at cardiac output, so oxygen content, we've now gone to how to kind of optimize that. But oxygen delivery and cardiac output, or related to cardiac output, has also got a lot of different factors to it. So we said heart rate times stroke volume, and heart rate is an easy one. We know that children are way more dependent on heart rate to maintain adequate cardiac output, and that's often why if a child is shocked, they push up their heart rates very quickly to maintain their adequate cardiac output. So if a child is bradycardic, you need to know that they are almost always going to arrest on you very soon if you don't get their heart rate up. Okay, so heart rate is a very sensitive, or one of the best markers for me to assess children in shock. And you're almost not happy about their heart rate going up, but a tachycardia in a child is not always a bad thing, because they're actually very dependent on that to maintain their cardiac outputs. But now if we look at stroke volume. So stroke volume, we said, is related to preload, contractility, afterload, and there's so many hormones and the filling of the heart and venous return that contributes to that. And we know that's one of the things that as intensivists, we wish that there was a much easier way of measuring stroke volume, and specifically afterload and preload easily. So we've got all these echoes and invasive and non-invasive monitoring, but there's not really a very easy way to just assess stroke volume to know whether it's adequate or non-adequate, because so many things contributes to it. So that is often the difficult part, where it's not that easy to assess whether someone has got adequate stroke volume. Okay, so you need to look at all the different aspects. But it basically comes down to you need a heart that can contract well, you need it well filled, and you need to make it as easy for the heart as possible in terms of afterload. Okay. So just looking at this, I might have showed it to you last year when we did the ventilation talk, but just looking at oxygen delivery, and you can have a look at this graph. If you look at the very first dark black patch, you can see that that patient comes in, it's got a very low oxygen delivery. He's sitting at an FiO2 of 21%. His PaO2 is around about 6, where we know a normal PaO2 is 13. SATs is sitting at 75, the HP is 7, and the cardiac output is low, it's sitting at 4. So you can see that's why the overall oxygen delivery is quite low. It's sitting around about 300 milliliters per minute. If you now look at the second bar, you will see the only thing that changes there is the FiO2 goes up to 35%. Just by increasing the FiO2 to 35, the PaO2 will automatically go up. So that's now sitting at 9. The SATs goes up to 92 because of that. And that makes already quite a difference to your oxygen delivery. But your HP is still 7, and your cardiac output is still low, sitting at 4. With the next bar, you can see the FiO2 is now sitting at 60%. The PaO2 has gone up to 16, so your SATs is higher. So just by doing that, your oxygen delivery goes up another 9%, but your cardiac output is still low, and your HP is still low. If you then increase your HP to 10.5, you can see all of a sudden your oxygen delivery improves to 48%. But if you actually treat your cardiac output, and that's probably the mainstay of why the oxygen delivery was so low, is because of cardiogenic shock. If you can get your cardiac output up, you can see it actually increases your oxygen delivery remarkably by getting your cardiac output up. And I think that to me is all about what the oxygen delivery formula is about. It's not just treating one aspect of it, but look at all the different aspects. And I think with all the controversies on hemoglobin and transfusions, we don't normally just take a HB, or in these days, now that we know that a transfusion is not just a free ride, we don't just give blood and get the HB up to 10. We actually look at all our other parameters and try to optimize those things. But if you've got a patient in shock and you are needing high inotropes and you are unable to wean on those, it might be worth getting your hemoglobin up so that you can improve oxygen delivery to the tissue. Okay, so now just a little bit about the hemodynamic response to shock. Okay, so we always talk about compensated shock, decompensated shock, and then some people will talk about irreversible shock. Okay, and it's really at irreversible level that we don't want to get. So we want to try and catch a patient while they are still in compensated shock. Okay, so pick them up when their heart rate's the tachycardia, especially in children. When the child has got a tachy, they often warn you that they are now in compensated shock, so they're trying to compensate their cardiac output by pushing up heart rates. And once they start decompensating, and their blood pressures are dropping, it's really a very late sign, especially in children. Okay, if their blood pressures have started dropping, they're mostly in.
Oh, I think you're back now.
Can you hear me?
Yep.
Yeah, you're back on now?
Okay, great. And you can see the presentation now, right?
Yes, we can still.
Okay, great. Okay, so it's really, you don't want to get into decompensated shock, because that is the track that you're going to follow into irreversible shock. So compensated shock, you can still catch them. Okay, and you can see blood pressure is quite a late sign. If that starts dropping in children, you know this patient is in decompensated shock. Okay. So one thing in children that we need to remember is that blood pressure is not blood flow. Okay, so the equation to work out blood pressure is SVR, so systemic vascular resistance, times cardiac output. And again, SVR is something that's quite difficult to measure. So, and with cardiac output, we often need to do some non-invasive tricks with ultrasounds and stuff to know where we are. But if you look at these two pictures, it's actually of a patient in septic shock. And if you look at the normal picture, you can see that's how the vasculature, the microcirculation normally looks. On the right-hand side, you can see the vasculature or the microcirculation of a patient that's in septic shock, but it's actually got normal blood pressure. But you can see there's very little flow to that in that circulation. So definitely decreased perfusion and decreased end organ perfusion, but the blood pressure is still normal. So we really need to remember that although we need to do blood pressures, when they start dropping, a normal blood pressure doesn't mean there's normal blood flow to tissue. Okay. So if we then talk about different shock states, and we often learn about the 5 different types of shock. For me, an interesting thing about cardiogenic shock, that it's often different type of shock states that is present in a patient in cardiogenic shock. And I'll show you that now as we go through the different types of shock. So we know about cardiogenic shock, we know about dissociative shock, obstructive shock, distributive and hypovolemic shock. And often in a patient with cardiogenic shock, we can appreciate that they might come in a little bit hypovolemic. And a lot of pediatric cardiogenic shock is actually an obstructive type shock if you think about coarcts and hypoplastic arches and hypoplastic left heart syndromes. Has also got a component of obstructive shock. So I'm going to take you through a bit of the pathophysiology of what we see in cardiogenic shock in children. Okay, so if we think specific about our cardiogenic or our cardiac patients, if you think about cardiogenic shock, it's often because of pump dysfunction. Okay, and some of the causes, the most common causes that we see for that is because of dilated cardiomyopathies or a myocarditis patient, and it's because of poor contractility. Okay, we've got quite a lot of patients with infective endocarditis or acute rheumatic heart disease that's got valvular problems, and that's why they present with cardiogenic shock. your left ventricle obstruction, arrhythmias, and then low cardiac output syndrome, which a lot of our, I'm sure that a lot of the EM registrars that's worked with us has seen some of our post-op cardiac patients in low cardiac output syndrome. And it's often precipitated by a combination of things, a bit of SIRS post-op, some arrhythmias, junctional ectopic tachycardias that drives them into a low cardiac output state. So that is when you've got pump dysfunction. Okay. When you've got an obstructive type of shock state, that often happens because of a tamponade, because of pericarditis or a pericardial effusion, tension pneumothoraxis. We don't see a lot of pulmonary embolisms, but obviously that is also a cause, severe hypertension, and then your coarcts, like I previously mentioned, hypoplastic arches, interrupted arches. So that's quite things that we see quite often in children, and we will go through the management of those kids. Then a lot of these children, if they are sick, they start not drinking that well, they start vomiting. A lot of, especially neonates, when they are sick, they present with diarrhea. So there's, in a lot of them, a hypovolemic component. And it's often difficult to know how much fluid do they need, because they are also cardiac patients, so you don't want to give them too much. So you always need to think there might be a little bit of inadequate filling as well in these children. And then the distributive or vasoplegic component of shock state, thinking about sepsis, inflammation, SIRS response, and that's often present in our post-op cardiacs, that you feel like they've got like a 4-hour honeymoon period, and then as the cardiothoracic team and the cardiologists leave the premises, they leave you with an unstable patient in low cardiac output syndrome. And it's often when they start having temperature spikes from their SIRS reaction that they vasodilate and they get this distributive shock. And on top of that, they've got pump dysfunction. So you often deal with more than one of these issues. And also a bit of dissociative shock. So if they've got severe anemia, you also have a dissociative component. So you really need to think about different states that your patient can be in and how you can optimize each of them. Okay. At this stage, is there any questions? If you've got any questions, just put it out in the chat, or you can just unmute yourself and ask, and I hope that is quite clear. So that's just a little bit about the pathophysiology. So if you look at cardiogenic specifics, so there's most of the time this patient has got a myocardial insult that leads to systolic dysfunction. If you've got an obstructive component, we say tamponading or decreased filling, decreased forward flow out of the heart. They can be hypovolemic, so preload is a problem, and then distributive shock itself or sepsis of itself leads to myocardial dysfunction, and all of that eventually causes systolic dysfunction, which leads to decreased cardiac output, decreased perfusion, shock, and that if you don't have good organ perfusion, you're going to go into multi-organ dysfunction syndrome. So you're going to develop, your other organs are going to go off. So liver dysfunction, kidney dysfunction, often in these children especially, we see bowel problems. They become confused as they don't perfuse their brains that well, and that's when you go into your end organ failure. So I've put this slide up here just to show probably the most common causes that we see in children, but I will also show you just now the extensive list of things that you do need to think about if you have a patient in cardiogenic shock. So in small babies, congenital heart disease is definitely the most common cause that we see, the reason for coming in. We also see a lot of DCMOs, myocarditis, and you shouldn't think that if it's a small baby that they can't get a dilated cardiomyopathy. We have patients that present with a congenital dilated cardiomyopathy and non-compaction, and they can present quite early in their lives. Arrhythmias, and then PPHN, which we'll go through, so persistent pulmonary hypertension of the newborn, and they can sometimes throw you a little bit, because your echo can be quite normal, but you just don't know why your baby is not saturating well. Then in the older children, it remains congenital heart disease, DCMOs, infective endocarditis, acute rheumatic heart disease, arrhythmias, and then trauma is another thing to think about. But if you look at the extensive long lists of things, I quite like to divide it into left ventricular failure and right ventricular failure. And you often need your echo to guide you on what side is the problem, and obviously your clinical assessment. But if you think about left ventricular dysfunction or failure, you can often divide it into, is it a contractility problem, so systolic dysfunction, or is it actually a filling problem where you've got a stiff ventricle or a restrictive cardiomyopathy and the heart can't fill and pump well? Or do you actually have increased afterload, like we see with our coarcts and aortic stenosis, or is it a valvular problem, or is it arrhythmia? So it's a very nice way to also break it down, what can be the potential cause for cardiogenic shock. If you then look at your right ventricular failure, you can also specifically think, is it systolic, so is it decreased contractility, or is it increased afterload? We often see children with pulmonary hypertension, and a lot of them with obstructive sleep apnea, and the patient with acute respiratory distress and pneumonias can often present with right ventricular failure, and then arrhythmias is the other thing to think about. Okay, so just to wake all of you up now, we're going to do a little bit of a case study, and this is now here where I really need you guys to try and answer the questions, just so that we've got a little bit of interaction and that I can see whether you understand the things that I've been trying to explain. So this case study is about a 2-day-old little term baby, born NVD, with a history of meconium-stained liquor at birth. Okay, UPCARs was 2, 4, and 9, and initially transferred to the mom after birth and then discharged home a few hours later. And now at day 2 of life was brought in by the mom after she noted that this baby is grunting, she can't get the baby to latch well, the baby is not feeding. And on arrival, the baby is cyanosed with SATs in the 50s and really poorly perfused and shocked. You can't really hear a murmur, but there is some response to oxygen, but only to the 70s. Okay. So I want to know, what do you think the differential diagnosis is on this little baby? You can ask me questions to get a little bit more information if you want. But what would you do in terms of your diff, and what workup do you need to get to the conclusion? And then we'll talk a little bit about management. Okay. So I don't know if I can maybe ask Mary, do you want to comment a little bit and tell me what you think, what the differential diagnosis might be?
Hi. Well, she seems, so she's cyanosed, so she's got a cyanotic issue with obviously sort of like failure now. So I would think of something ductal dependent, some cyanotic heart disease. It's ductal dependent now. The duct is.
So what type of conditions is duct dependent this early in life?
I want to say a Tetralogy of Fallot, but I might be wrong.
So your right-sided, your right ventricular outflow tract obstructions. Yes, so that's one possibility.
Yeah, or might get it out. If anyone else has any ideas? But
okay, so yes, I think that definitely needs to be top of your list, because there is some response to oxygen, but the SATs is still sitting in the 70s. I think this child being shocked is normally, if it's just a tetralogy if it's a tetralogy of Fallot, they don't present that early. So it needs to be something like a pulmonary atresia or a critical pulmonary stenosis for them to be at day 2 of life with this duct dependent. The other thing that we need to think about is PPHN. Okay, so persistent pulmonary hypertension, especially with that history of meconium-stained liquor. The baby might have meconium aspiration, and now have gone into a cycle of pulmonary hypertension. But we'll go a little bit through the details. So thank you so much, Mary. You are off the hook. I'm going to go through the cardiac emergencies in a neonate, and it's sometimes difficult to distinguish between respiratory cause and cardiac cause. Okay, so here's just a very nice summary that is from George Comitis, that works at Red Cross, that he wrote an article specifically about emergencies in the little babies and how to try and distinguish. And I think history becomes very important here. So we don't have routine antenatal scans on everyone. So we don't know that every baby that's born, we don't know exactly how their heart is looking. But the things that we can ask is we can specifically ask whether the mom had diabetes. Because if it is an infant of a diabetic mom, it makes them a little bit more prone to some cardiac conditions, and also to pulmonary hypertension at birth. Whether it was a difficult delivery, was there hypoxic ischemic encephalopathy at birth, and was there meconium aspiration. Preterm babies on their own can get quite severe PPHN. And then if there is the history of an antenatal scan, that obviously makes it a little bit easier for us if there is a known cardiac condition. So you also want to know whether there was respiratory distress present at birth, and whether this can be a congenital pneumonia. And I think the response to oxygen is quite important. So we still often do a hyperoxia test, and that's basically defined by giving someone 100% oxygen for 10 to 15 minutes, and then to see whether the PaO2 improves to more than 150 millimeters per mercury. If you can get the PaO2 that high, then it's very unlikely to be a cardiac condition. And then always remember about the pre and post dactyl SATs. So if you measure SATs on these days, you always want to have it on the right hand, and especially in PPHN, that's quite a nice sign. If there's a more than 10% difference, then there's a very high likelihood of that patient having persistent pulmonary hypertension. Okay, so chest X-ray, there's not, I must say, at birth, there's very few hearts that you can look at the X-ray and say this is definitely an egg on the side, or so there's not always a pathognomic chest X-ray picture, but you do get some conditions that you can say this is definitely looks like a tetralogy or a RVOT obstruction, but often it can be non-specific, but it's still important to do them. Okay. And the same with the ECG. It's important to do them and read the ECG, but it's very difficult to make specific diagnoses just on an ECG. And essentially, you need an echo if you think about the patient having a cardiac condition. But especially in the emergency department where you guys work, that is an absolute luxury, and you often need to depend on your history, your clinical examination, and you need to make a call of what emergency treatment to start. And then the response to that is often going to lead to what your diagnosis is. So just going through the most common cyanotic conditions in children. I'm sure you guys have done this before, but just to remind you about the 5 T's. Okay, so normally with the 5 T's, you can work out most of the cyanotic spectrums. So you might not get to that absolute specific diagnosis, but you will hopefully identify on which spectrum that patient is. So Tetralogy of Fallot is probably the most common cyanotic heart condition in children, but on a day 2 old baby, they will very rarely present that cyanotic and that shocked and that duct dependent. So then you need to think about something like pulmonary atresia, which is obviously on the spectrum of a tetralogy, or a critical pulmonary stenosis. TGA is the second most common condition, and they can actually be quite blue initially. And they are often duct dependent if they've got adequate PFO. Okay, so we'll go through TDA management just now. Tricuspid atresias, TAPPD. TAPPDs often present a little bit later, and they can often look like cardiac failure patient that is blue, and then truncus arteriosus, and we'll go through that as well, and then PPHN is the one thing to think about. In this specific case study, this patient had a critical pulmonary stenosis. Okay, so what will the emergency treatment be of a neonate that is deeply cyanosed, shock, and in respiratory distress? So you're going to start with your basics, like always. We do A, B, C, D, E, F. Okay, so you're going to give the baby oxygen. So oxygen is a potent pulmonary vasodilator. But if someone is duct dependent, you need to remember that if you give them high concentrations of oxygen, you've got a higher chance of closing the duct. So it depends on the diagnosis on what you want your SATs to be. But if you had a patient that presented with SATs in the 50s, if you don't know exactly what the diagnosis is, you want to open up the PDA as soon as possible. So we have IV Prostin, but not all institutions have IV. So then an oral tablet or half a tablet is often acceptable, and you can repeat that every half an hour depending on obviously the response and the diagnosis. But get the PDA open as soon as possible. And there's very few contraindications for starting Prostin. So rather, if you think about it, rather give it than not give it, especially in a young neonate that you're expecting to have a duct-dependent lesion. Fluid bolus, so be cautious, start low. We've said a lot of these children haven't been feeding well, so there might be a preload component, and you want to improve that, especially if you are dealing with a right ventricular outflow tract obstruction. So it will also help you to encourage flow through that PDA once you open it up. So fluid bolus 5 to 10 moles per kg of Ringer's lactate is what we would normally use. These are some of the rare circumstances where we still use Inotropic. So if you are severely asymptotic, it's going to worsen your hypoxic pulmonary vasoconstriction, and you're going to have worsened PPHN or pulmonary hypertension. So you want to vasodilate the pulmonary side a little bit to get blood flow across that side. So you can consider giving some Inotropic. You want to correct all the electrolytes, okay, so calcium, magnesium, potassium. And then if there's a sepsis component, you want to make sure that you treat that. So in children, often, I think every single one gets a KEF dose that just walks into this hospital, which is probably appropriate because so many children are septic on presentation, or it's the infection that pushes them over. So make sure that you treat the sepsis, or at least get antibiotics, and you can always stop it within 24 to 48 hours when you review the patient and septic markers. And then inotropes or vasopressors to maintain systemic perfusion. So you want to make sure that you've got adequate mean blood pressure. So for a little neonate, mean blood pressure is 40 to 45 to encourage pulmonary perfusion. And you want to increase the systemic vascular resistance. So in children, we often start off with adrenaline. In a child like this, you want to try and avoid something that is going to cause afterload reduction. So you don't want to use something like milrinone or dobutamine to start off with, maybe a low dose adrenaline. And then just depending on what the response is to maybe high flow oxygen, to opening up the duct, to the fluid bolus, you might or might not need to intubate and ventilate a patient, depending on what the response is to the emergency treatment. Dependent, that would be the emergency treatment. So just a little bit about Prostin or prostaglandins. So like we said, there's no true complete contraindication. You should never withhold it if you think about a duct-dependent lesion. There is side effects. So often, especially if you use high-dose IV Prostin, you often need to intubate the patient for apneas. They can go hypoglycemic. And a lot of our babies waiting for surgery on Prostin develop temperature spikes. And then it's very difficult to clause out, is this now sepsis and they can't be operated on, or is it actually the Prostin that's causing the temperature spike? So just bear in mind those possible side effects of Prostin. We do get conditions where it won't be effective to start Prostin. So if you've got a TGA and you don't have a PFO, flow across the atrium, Those patients, you can give them Prostin until you are blue in the face. If you don't get a septostomy to encourage mixing, you are not going to win with just Prostin alone. So if you suspect a TGA, they need to be referred obviously to a center where a septostomy can be done and where you can encourage mixing. And then for a TAPVD, it might actually worsen pulmonary venous congestion if you start Prostin. But again, it's very difficult to know whether it's a TAPVD or a TGA in that acute setting. So rather start the Prostin, and if you don't see a response, then stop giving it. But I don't think you should withhold it if you are, if TAPVD is one of the things that is on your problem list. I think rather give a dose and see what the response is to that. Okay. So just something about persistent pulmonary hypertension of the newborn. In the management of those patients, they often need to be intubated and ventilated. Okay, so often when you get one of those babies and there's a history of meconium aspiration, or the baby is an infant of a diabetic mom, there was some hypoxia at birth, or it's a preterm baby, and you highly suspect that this baby might have PPHN, you often need to intubate and ventilate them. And there's often a big discrepancy between their preductal and their postductal sat, so often more than 10%. And they often need fluid, so fluid bolus to encourage forward flow through the lungs, and they normally respond extremely well to nitric oxide. Okay, some of them will have a partial response to a bit of Prostin as well. So again, if you do start a bit of Prostin when you are unsure about the diagnosis, it's not going to cause harm specifically in PPHN. You want to drive their systemic blood pressures a little bit up to overcome your pulmonary hypertension. So you often need to start a bit of adrenaline. Some will say adrenaline with a little bit of dobutamine if you work in our nursery at Critisky. That's kind of what they currently use. And then you want to get the pH above 7.25 at least. You want to try and not use too high pressures to ventilate them with. So they often respond quite well to oscillation to get their CO2s down. But it's just always something to keep in the back of your mind, especially in a small baby, especially in the preterm babies. If there was a little bit of an aspiration episode, they can often present to you very hypoxic without having a cardiac condition, but they have PPHN. And what you see on echo is often a PDA or a PFO and a little bit of tricuspid regurg because of the severe pulmonary hypertension and then obviously high pressures on the pulmonary side. So it's just a condition that can catch you out quite easily. Okay, so thank you, Mary, for answering that one. I'm going to ask, can I ask Emily maybe to answer the next one? But yeah, anyone can answer, but yeah, maybe help Emily a little bit. So this is the next case study. So we're still on cardiogenic shock, and we're still on in the neonatal period specifically. So we now have a day 10 of life little term neonate. He was actually well at birth. He was discharged on day 2 of life, and normal delivery with good UPCAR, so no perinatal hypoxia. And now we present to you in the medical emergency department with respiratory distress, some vomiting, the inability to feed for a day, and he's centrally pink, and he's alert, he's looking at you, but he's irritable. His heart rate is sitting between 180 and 200. His cap refill time is 5 seconds, and he's cold and shut down peripherally. Okay, so day 10 of life. So what do you guys think? What is the possible differential diagnosis of this little baby?
I just wanted to clarify, you did say Emily, right?
Yeah, so anyone can, yeah. Can, but I mean, give it a go. You might be right.
Oh no, this is not stressful at all. Okay,
Yeah,
so
you should be in a place or like feel like you're on the spot. I think just see what you think. If this baby presented in front of you, what would you do for this baby?
okay, so we're talking about a day 10 of life term neonate. You always have to consider a congenital heart condition.
Yes.
So the kid is, the infant is actually centrally pink. So we're thinking non-cyanotic congenital heart problems. And then also further down on the list, we would also then, I don't know if 10 days is quite early, but then also your myocarditises. I don't know if you would consider that. I think it might be a little bit early. Congenital, you mentioned early congenital dilated cardiomyopathies. So yeah, I don't know what else you want me to say.
Type, if you have to think about your congenital heart disease, what do you think, which type of congenital heart disease will this be?
Centrally pink, alert but irritable. I don't know if VSDs are common, but I don't think it would cause a cardiac shock like this unless there's something pushing baby over. Sure, I don't know. I would.
Yes, definitely. I think VSDs, they don't normally present this early in life in cardiogenic shock, but later in life, it's definitely one of the things that you need to have on your problem list. So we'll go through that now. So what workup would you want to do, Emily? You're doing very well. Okay, so what workup do you need for this baby?
Okay, so basic, you would need your basic workup in this infant. So you would need your septic markers, your blood cultures. You would definitely request an X-ray if you could see any cardiac abnormalities, or any respiratory abnormalities together with that. And then obviously also an echo as early as possible to identify any cardiac abnormalities. I think that's what we would be able to cover, or that's what we'd be able to cover early on.
Yes, okay, so I think that's a nice broad of what we can do, and then we'll go through the emergency management now. So thank you so much, that is exactly right. So if we then go get back to our case study, can you guys see the presentation again?
Yes, we can.
Okay, great. Okay, so if we go through what the potential diff diagnosis can be, you're completely right. Like group B strep sepsis can throw you completely, and they can look like this. They can be shocked, very poorly perfused, and they normally present around about like in the first week to 2 weeks of life. So you need to think about sepsis always in this age group. But your critical left ventricular outflow tract obstructions, they still perfuse their brains often, and so they are often looking at you. They're irritable, but they are awake and alert, and you always need to like it's really a sad condition because we can't really treat them in South Africa, or we don't do surgery for them. And then your critical coarctations, interrupted aortic arch, and just in the last 2 weeks, maybe Mary can help me, but I think in the last 2 weeks we've had about 3 coarcts. So it's very common condition that we often see in small babies less than 2 weeks old. But the 2 things you always need to remember in neonates is about your inborn errors, okay, especially with a high lactate, being shocked, and congenital adrenal hyperplasia. So always look at their sodiums and their potassiums and their glucoses, because those are the 2 conditions that you don't want to miss. Okay, so that is your differential diagnosis. So previous case, we spoke about right ventricular outflow tract obstruction. This time around, we talk about left ventricular outflow tract obstruction. So you've got flow to your lungs, but you actually can't get flow to your systemic side. So getting out of the left ventricle, you've got an obstructive issue. So you've got obstructive shock, which normally causes myocardial dysfunction as well, which leads to cardiogenic shock. So you've, again, got more than one type of spectrum of shock. So what is the emergency treatment going to be? So maybe I can ask Boyke. Boyke, I saw you are on, can you maybe tell me what the emergency treatment would be for this little baby?
Yes, good afternoon. Can you hear me?
Yes, I can hear you well. Are you well?
Yes, I'm well.
Okay, sorry for
so
putting you
I
on the
think
spot, but seeing that you were in ICU recently, I thought maybe you can just go through the ABCs and see what you think how we need to get this baby better.
so what I think the baby needs to be started on some oxygen, and
Yes.
we need to get in terms of management of connect some monitors and go on to manage her.
Yeah.
See where we'll get IV lines, and I think it would be wise, because the capillary fill was 5 seconds. I think it would be wise to start on some IV fluids, maybe at a low of 5 to 10 mils per kg bolus, and assess response.
Yes.
And then I think in the end, the baby will need to be started on some inotropes.
Yes. And what else?
What else?
Why do you think at day 10 of life, this baby is now decompensating? So what normally happens around about day, like anything between day 3 and day 14 of life?
So they probably, the PDA has closed.
Yes, okay. So
And if we can start them
before
on
you do
prostate.
inotropes, you're first going to do the prostate. Okay.
Yeah. So
you're going to get the first dose of prostate in. Okay. So you are.
The child is going to need, so the child might need infusion until theater, then that means we will intubate the child. And yeah.
Okay. So thank you so much, Boyke. That is absolutely right. So always do your ABCs. So critical care is easy. If you can do your ABCs well, you can be a very good intensivist, and then to keep on reassessing. So we're going to start this little baby on oxygen and aim for your preductal sats, because that is what reflects what's going to the brain. So if your preductal sats can be more than 85%, you know you are perfusing the brain. Start on prostin, give a careful fluid bolus. So I agree with the 5 ml per kg, watch the liver. And then a low threshold to intubate and ventilate those babies. And it's often for me in an ICU setting, it's more about getting control of the situation, being able to put in central lines for these small babies. So if you start CPAP and your baby is responding well just to CPAP, high flow and oxygen, and the lactate is coming down, and you can see that the baby has responded to the prostin, then you don't need to rush and intubate. But if you feel like the baby is not getting better after your initial measures, then they often need intubation and ventilation. Inotropes, so again, if we start inotropes, it will always be after the prostin, and it's mostly to maintain organ perfusion, because you want to make sure that you get your diastolic blood pressures at least above 25-30, so that you get good perfusion into your kidneys and good coronary perfusion. You want to make sure that you optimize the electrolytes. And these babies with coarcts, especially the later they present, they can often have quite severe acute kidney injury, severe liver injury, and they are at extremely high risk to develop necrotizing enterocolitis or gut dysfunction. So you keep them null by mouth, and we often keep them null by mouth for a couple of days until we are sure that we can start some feeds and that the perfusion to the gut has been optimized. So watch for end organ perfusion and try to maintain good blood pressure. So again, mean blood pressure is above 40 to 45 for a day 10 baby should be adequate. Depends on if they just have alveolar obstruction, but a lot of these babies, like now we've got a baby with a hypoplastic arch, a critical coarct, and AVSD. So then they become a little bit more complex, but in the emergency setting, you are still going to do exactly the same type of things. So gentle fluid, make sure that you start your prostin, get your preductal sats up, and basically if you can do the ABCs well, they need to get to a unit that can actually do surgery for them and continue to manage them. Okay. So well done. Boyke, is there any questions on this specific case? You guys quite clear on the management of left ventricular outflow tract obstruction. So very much the same as right, but they're not going to be as cyanotic, and they're going to have a better response to oxygen. and they often have quite severe cardiac dysfunction, so they will often need inotropes on top of the prostin. Okay, so let's do another case study. Okay, and maybe I can put, who am I going to put on the spot now? Sorry, maybe someone can actually volunteer to answer this case for me. So this is a 2-week-old little neonate, and we're still in the neonatal phase of cardiogenic.
Sorry, Martie.
Yes.
We just have a question in the chat part.
Yes, okay, for now, yes.
Regarding the previous case, just a question, yes, whether we would start antibiotics or not.
Definitely. Okay. So did I not say that? So at point number 7, we're going to correct electrolytes, and we're definitely going to start antibiotics. So we'll definitely treat it still, because you are not going to know exactly what's going on in your emergency department. You're going to kind of make the temporary diagnosis of a possible cardiac condition, a possible duct-dependent lesion, but you don't know if this is maybe a septic shock or a neonatal sepsis. So you're definitely going to give ceftriaxone. So if it's a baby that wasn't recently admitted to hospital, you're going to give ceftriaxone. We normally give 100 milligrams per kg stat, and then we'll start 50 milligrams per kg of cefotaxime in the ICU 6-hourly. And you can add some AMPI to that, because you just want to make sure you cover for listeria. So you definitely need to treat for sepsis. Anyone else want to ask something about that case? Okay, so thank you Cornell, for bringing that up, but you'll definitely give that baby some antibiotics on top of that. Okay, so 2-week-old little neonate. You can see there's an X-ray up for you. There's an ECG that presents with respiratory distress, unable to feed for 3 days now. The heart rate is 200 per minute. It's got some bounding pulses. The liver is 4 centimeters. You can see a little bit different than our previous 2 cases. And on this little baby, you can actually hear a loud ejection systolic murmur. Okay. So SAT is actually sitting in the high 80s, low 90s. What will the differential diagnosis be on this specific baby? Okay, so we're getting a little bit of a different vibe than on the first 2 cases. Okay, anyone want to nominate themselves? Otherwise, I'm going to choose. So just imagine this baby is sitting in front of you in the emergency department, and you need to do emergency treatment for them. What will you do? Okay. Who can I ask? Can I ask maybe Elmarie Skuman? Do you maybe want to give me an ABC rundown on this baby? I know there's a no. Anyone else? Okay. Maybe David, do you want to give us a bit of a clue? Yes.
Hi, there we go. Sorry, my mic was off. I said you've probably chosen one of the most junior ages, but I'll give it a go. I've just started.
Okay. And I promise you the next month you're going to get a baby like that. It normally works like that.
I hope not so. So I would probably say, so firstly, just ABC approach. So we'll be looking at, airway. So also just to start some oxygen, because you mentioned the SATs below. You also mentioned, well, the case study says that the baby's got an enlarged liver. So I'm thinking maybe the baby is in heart failure. So I wouldn't just grab for fluids over here. Yeah, and then looking at a cardiac point of view, looking at the ECG, one of the things to consider is with that high heart rate is the baby got arrhythmia. But on the ECG, I mean, I can see P waves, so I don't think it's a SVT that needs to be treated at this point in time.
Put a bit of an arrow there for you as a clue. So you definitely, it's got a sinus Jackie.
But yeah, I think for a diff diagnosis, perhaps somebody else can help out. Yeah, I'm lost. I'm not sure.
Okay, anyone wants to help her in terms of the differential? So we think that might be a congenital heart condition, but what are we thinking about? So in a 2-week-old little baby. Okay. So we previously spoke about our RVOT obstruction, so more right to left, and then we spoke about prostin-dependent left ventricular outflow tract obstructions, and this case demonstrates a little bit more of left to right shunting, or kind of a mixer, and we'll talk through the different conditions, but truncus arteriosus is one of the things that comes to play. So if we think about congenital heart disease, left to right shunting, then you're right to like to think about VSDs, large PDAs, to think about AVSDs that might cause a bit of mixing, and then our truncus arteriosus, even TGAs can present with SATs in the 70s, 80s, tachyarrhythmia, but she's obviously pointed out that there is P waves, so we don't think it is a tachyarrhythmia. And then dilated cardiomyopathies, myocarditis. Like I said, we can actually get them quite young, where they present at an early age of a month or 2 months old, and often have like a congenital type dilated cardiomyopathy. So it's definitely something to keep on your list. But if you hear a loud murmur, you need to think about whether this is a large VSD or a truncus arteriosus. And this specific baby, it's got a truncus. Okay, so a truncus can be quite complicated, especially if they have too high SATs. They can develop pulmonary hypertension quite early in their lives. So you do want to give them oxygen. You do want to give them probably in the form of CPAP, because this baby has respiratory distress. But you also want to avoid very high SATs. The higher the SATs is, the more flooding you're going to get to your lungs and the less systemic flow you're going to get. So you want to balance that so that you've got adequate forward flow systemic perfusion, and that all your blood doesn't go into your lungs. Obviously, that's going to be a little bit difficult in the emergency setting, because you're not necessarily going to know that he is definitely a truncus, but it's something to anticipate. So if it's a truncus or even a VSD, AVSD, you don't necessarily want to aim for 100% SATs. Low 90s, high 80s is perfect. Be very cautious with fluid. Like you said, Elmarie, you don't want to give fluid. There's already a massive liver of 4 centimeters. But bear in mind, this baby did not feed well for 3 days already. So might need a small fluid bolus, but I think I'd probably stay clear and first see whether CPAP and diuretics don't make a difference. Might need a little bit of dobutamine initially to just support the heart and to get perfusion up to your end organs. And then again, it's a 2-week-old baby. Neonatal sepsis always needs to be on our list of things, and especially your babies with left to right shunting, like your VSDs, AVSDs, they present with lung infections very often, and it's very difficult to clause out, is this cardiac failure, is it a lung infection, is it the combination of both? So you often need to treat them like they've got a new infection. Need to make sure you optimize the electrolytes, especially in babies with truncuses. They are prone to 22q delusions, so they've got calcium issues. So you often need to check the calcium on these children, and then, like I said, start some antibiotics. Okay, so just to talk a little bit about if there's poor mixing in your cyanotic lesions, so a transposition of the great arteries. So normally blood flow from the right atrium to the vein in these children, not normally, in these abnormal children, normally blood flows from the right atrium to the right ventricle and then go into the aorta, because they've got a switch around. Their aorta comes off the right ventricle and their pulmonary arteries comes off the left ventricle. Then you want to make sure that there's adequate mixing. So you want to make sure they need to have an adequate PFO. And obviously in the emergency department, you can't do much about the ASD if it is a restrictive PFO. They need a sectostomy. If they've got a PFO and they've got a reasonable VSD, then normally there will be adequate mixing. But if they've got intact VSD and only an ASD, you need to open up the PDAs. So again, a TGA and a baby that presents in like at 2 weeks of age present to you cyanotic and you're not sure what the diagnosis is, you're going to start them on some prostin. And the only conditions where they're really going to get worse is if it's something like a TAPBD, then the prostin might not work or might cause more flooding of the lungs. But for most of the conditions, you're going to start prostin on them. So you want to make sure that you've got adequate mixing in those babies. Okay, so how much oxygen can I give? And that is very much for your truncuses, for your TGAs, and it's good to think about what your lesion is and what your right-hand SATs are showing. So your right-hand SATs is often going to show you what perfusion is going to the child's brain. Okay, so in your babies with left ventricular outflow tract obstruction, okay, you're often going to have higher SATs in your right hand than in your left hand, if you think of where the obstruction is. So they're often bright and alert because they've got better perfusion to their brains. But in a patient with a TGA, where the aorta in the pulmonary arteries switch around, your right hand might actually show lower saturation than your left hand. And that's important to note. That's the one place that if you get a discrepancy in your SATs, then it might actually be a TGA. Okay, so it's important to measure left and right-sided saturation. So just to tie all of this together in terms of congenital heart disease, because we've now spoken about a lot of different conditions in an infant specifically. So just to look at the different types and how they present. So they can often be tricky to know whether they are a congenital heart disease, whether it's a myocarditis, whether it's valvular disease, whether it's just sepsis. Because how do they present? And they often present in respiratory distress, okay, and with or without cyanosis. And if it's just a deeply cyanosed child that is actually quite comfortable, the diagnosis is easier because then it's most likely heart disease. But if it's a patient that's cyanotic and in respiratory distress, it's often difficult to decide whether they just don't have a severe pneumonia. The older child that can just present in respiratory distress, those are often the ones with left to right shunting, and then you get the neonate that present in shock. And it's difficult because the differential diagnosis is always going to be, there might be a pneumonia. And in our setting, our cardiologists always say it's the lungs, our pulmonologists always say it's the heart. And often both of them are right. There's often a combination of a child with a heart condition that also has a pneumonia. But the neonate is often the tricky one because they can look like sepsis, but they can have a congenital heart problem. And that's why we need to have a low, a very high index of suspicion for that. So we spoke about right to left shunt. So that's our initial baby that presented very blue with low pulmonary flow. You can have left to right shunting. So those are the babies with a high pulmonary blood flow with your VSDs. And that's often your older child. A day 2, day 3 old baby don't really present in cardiogenic shock because of a left to right shunt. And they are normally pink because they're flooding their lungs unless there's another lung infection and component to them. Then your duct-dependent lesions, and that's often the baby that's in that 2-day to 14 days, some babies even up to 21 days that present to you when their duct closes and they present in shock and often quite extremist. And they can be quite scary. So now we're going to go to the older children and looking at the different causes of shock in them. And it's pretty much the same, except we see more infective endocarditis and kind of rheumatic heart disease in that group of patients, and then more myocarditis and arrhythmias as well. So this is you can obviously see the very blue lips. And again, I want to ask if anyone wants to answer this. So it's a 1-year-old boy that presented to your emergency department with severe cyanosis. He's in severe respiratory distress. He's got a heart rate of 180. The mom says that he normally turns blue when he throws a tantrum, but then he settles again. But today just didn't stop crying, and he is blue as anything, and he is miserable. So he presents to your emergency department. That is how his X-ray is looking. So what will the diagnosis be? Okay, and it's because we've touched on this now. So we've mentioned this diagnosis before. So it's just now an older child that presents, so the treatment is going to be slightly different. So anyone that wants to comment and give me a clue on what this can be. Come on, guys. Okay, maybe Cornell, or is someone willing to answer?
Hi, Marty. I'm just going to throw it out there because I've got to leave soon.
Okay,
Sorry, it's David speaking.
Yes,
I'm just thinking, just with that history and what he looks like, that, and with the X-ray, that I'm thinking probably more Tetralogy of Fallot in this case.
yes, absolutely.
That's what I'm concerned about. Again, you would have to, when you've got a cyanotic child, you've got to divide into respiratory and non-respiratory causes here. So I'd consider both of those. But the fact that he has it with tantrums, etc., that would be my biggest concern. I guess you would, again, with your workup, you could do a hyperoxia test when you're considering it, but I'd also want to do your basics, do your septic workup, do an echo on this patient, arrange early or an early echo and an early pediatric review as well. And the emergency department at the moment, if he's otherwise stable, yeah, I would probably just support him until I can get cardiology to have a look at him. And
yeah. So he's not that stable because his heart rate is going at 180.
Okay.
You do gas, he's actually a little bit acidotic. His lactate is up to 5. So what will you do?
Well, I would do I saw a brief thing. So, I mean, essentially managing a TET spell,
Yes.
which I'll be honest, I can't remember exactly at this stage.
Okay, good. So let's take you through that. So thank you so much. You're absolutely right. So just to refresh,
basics like improving preload. That's, I mean, you've got to basically improve the preload with these guys best you can, so that you can try and overcome his shunting. That's kind of the physiological principle that I recall.
Yes, that's absolutely the principles, and that's even the principle about the knee chest as well, to increase your SVR and to increase your preload. And that's what a lot of the treatment is based on. And what happens in them, they often go in, like, develop an infundibular spasm. So you often don't even hear a murmur in these children. So they come in and they are crying, and the thing that precipitates these TET spells, often crying and iron deficiency. Very often they've got a low MCV, but even a high HP, but they are iron deficient. Fever, so as soon as they vasodilate or they exercise and they run around, they vasodilate, and that's when they start spelling. So the emergency treatment, you want to keep him on his mom's lap because you want to try and keep him calm. And you just ask the mom to actually pull up their knees to the chest. You put them on high flow oxygen. So why the oxygen? We said previously, oxygen is one of your most potent pulmonary vasodilators. Okay, so you're definitely going to use 100% oxygen for him. And then all the books always talk about morphine as sedation. So you want to calm him down. You want to get a drip up for him. But ketamine actually works a charm in these patients. And often a low dose of 0.5 per kg increases the SVR and it calms them down. I find morphine takes a while to work and it often drops the blood pressure a little bit. So I'm quite a fan of giving them a little bit, a sniff of ketamine just to settle them down, that they can stop crying. And then this is the one heart condition that you're not going to bug over 5 ml per kg of fluid. You're going to actually give them 5 and 5. So you can easily give them 10 ml per kg of ringers, and you can repeat that and watch your liver, see if the liver is coming down. And that's to increase the preload so that you can actually get some flow over the pulmonary side. Another condition where we often give soda, because if they are acidotic, they actually get pulmonary vasoconstriction. So this is the one place where you want to run them more on the alkalotic side. And then if there's a poor response to that, and they are very hypotensive, and you're now getting to 20 ml per kg, they are quiet, they're not crying, and these measures doesn't work, then you often need to start them on something that will increase their SVR. So you don't want to use the butamine for them. You want to use something with alpha effect. So you're going to use something like NORAD or phenyl. All the books always talk about beta blockers, and yes, atrial. You want to relax and get them slow enough so that they can fill that right ventricle to actually pump blood across their pulmonary side. But if they don't have blood pressures and they are critically unstable, you don't want to give them beta blockers on top of that. So you want to make sure that you at least have a portable blood pressure, you filled them well with fluid, and you often need to start a little bit of inotropes and then get some beta blockers in there to slow them down. And again, we often in these children that is quite a critical tetralogy and a severe spell, we end up using noradrenaline with something like IV esmolol, but hopefully they will be with us by the time you need to run things like that. So do your ABCs first, and if all else fails, we've had a couple of these patients that end up needing an emergency shunt where none of your measures makes a difference. And it's remarkable to see these kids with SATs of 0 or 5% looking at you, and they are blue as anything, and nothing that you do actually helps them. So those are the kids that you need to consider for an emergency shunt. So get their SVR up, get them preloaded, get them a little bit more alkalotic, make sure that you calm them down, and if all of that doesn't work, then you will need to get something with alpha effect. Okay, I don't know, do I still have time? So I have another case study and then just something on inotropes. So I don't know if some of you guys need to go. It's now been an hour. You must just tell me if I need to stop. Okay. All right. So one more case study, and I'm quickly going to go through this. Is a 1-year-old little girl. She had a recent history of a flu a week ago, and she now presents to you in the emergency department with shortness of breath, grunting for a day. She's poorly perfused, the liver is sitting at 5 centimeters. She's got a heart rate of 180 and she's galloping away. Okay. Anyone wants to shout, what do you think? Or maybe put it out in the chat. What do you think this can be? Yes. Okay. Thank you so much. So someone is saying myocarditis versus respiratory. So I think the gallop and the liver is giving it away that this is most likely pointing towards a myocarditis, dilated cardiomyopathy, rather than just being respiratory. She probably has a pneumonia on top of that, but I think we need to have a high suspicion of a myocarditis. Okay, so what is our workup going to be and how are we going to manage this? So you can see there is the big bulky heart. Okay, also saying that there's something in the heart going on, most likely a myocarditis. We always need to think about pericardial effusions as well, so don't let them catch you out. So this is the dilated cardiomyopathy workup that we do for kids at Red Cross. So you can see it's quite extensive. It's not something that you necessarily got to do in the emergency department, but it is just all the different, there's a very long list of causes that can cause cardiomyopathies and myocarditis. In my experience, the most common thing is the viruses. So adenoviruses, RSV, rhino, enteroviruses. So often in the patients, everything comes back negative, except they grow a RSV or a parvovirus or one of the viruses. Okay. So emergency treatment. Okay, so again, it's easy, ABCs. So always just think about your ABCs and then keep on reassessing. So this is the little baby that you want to give a little bit of PEEP to. So to help them breathe and to cause some afterload reduction, try some CPAP early. This is not the child that you want to rush in and intubate. I've intubated a couple of these patients in my life, and I've at least lost 50% of them on intubation. They are extremely high risk. You need to prepare them very well before you just rush in and intubate them. Start them on some CPAP or high flow, start their inotropes, and be very, very cautious with giving them additional fluids. Get some diuretics in early for them, correct their electrolytes, give them some antibiotics, and try to avoid intubating them, especially early on. Okay, they will need a cardiology review, they will need ICU input, but these children are scary, scary, scary to look after in that initial phase. But they can also get better quite quickly once you start dobutamine. So you want to have an inotrope with a little bit of afterload reduction to help their left ventricles. But to start that, you do need reasonable blood pressures. So that's why my go-to inotrope is always adrenaline at low doses. And then you can always add in a bit of milrinone. If you feel safer with dobutamine, you can start off with that. But dobutamine do vasodilate them a little bit. So you need to know you've got stable blood pressures before you start that. Okay. So just in general, for all cardiogenic shock patients, we've got treatment principles. And again, it's looking at decreasing the oxygen demand and increasing oxygen delivery. So we've gone through the equation of life. How are we going to increase oxygen delivery? We want to increase cardiac output by improving contractility, which can be in the form of inotropes. We want to make sure that we afterload reduce them if it's appropriate. So you don't want to afterload reduce your coarcts, but you want to afterload reduce your myocarditis. So you're going to choose your inotropes based on your diagnosis. You want to increase your preload. You want to optimize oxygen content to increase your oxygen delivery. So that's SATs and hemoglobin. And you want to optimize your glucose and electrolytes. Okay. To decrease your oxygen demand, you want to make sure these babies, so any child, these myocarditises, patients with tetralogy, if they are restless and they are anxious and they are in pain and they're fighting you, they're going to look terrible. Okay, so often just calming them down, having them a little bit happier, it's much easier to assess them, and you will decrease their oxygen demand a lot. So using a little bit of clonidine, or for the TET, a little bit of ketamine, just calming them down. In the myocarditis patient, be very, very careful to give them a lot of sedation and analgesia because they are extremely brittle. Okay, so if they've got seizures or they shiver and they've got fever, you want to treat that and you want to help them with their work of breathing so that you can actually decrease their oxygen demand. Okay. So this is just, again, our principle of getting oxygen content up, looking at HP, SATs, and PO2, looking at your strokes, or that's supposed to be stroke volume, not stroke volume, looking at preload, contractility, and afterload. So now it's looking at the Starling curve. So I always think about the Starling curve. If you take a little elastic band and you stretch it, and you stretch it just right, it will go a far way. Okay, if you stretch it just a little bit, it's going to land here in front of you and it's not going to make any difference. Okay, and if you stretch it too far, it's going to snap. Okay, and that's exactly if you think about cardiac output in patients. Okay, so you want to increase your Starling curve by getting vasoactive drugs, by optimizing preload. But you don't want to depress the Starling curve by having hypoglycemia, abnormal electrolytes, acidosis, hypoxia, or a decreased preload. So you really want to find that fine balance and optimize things for your patient to improve cardiac output. Okay. So again, getting that balance right, increasing your oxygen delivery, decreasing the demand, and choosing your different treatment options for your patient. Okay, and this you can actually take for any patient that presents in cardiogenic shock. So what will be your resuscitation endpoint? So if you look at your patient and you've now done your best, you've resuscitated this patient, they are packed and almost ready to go to Red Cross, what is the things that you wanted to achieve in your patient? So it's often nice to look at your peripheral and central perfusion, okay, and you want to have that, the temperatures more or less in the same range. Okay, so those patients that are cold and poorly perfused peripherally, you want to get them better to a place where their central and their peripheral pulses are equal. You want to have a cap refill time of less than 2 seconds. Blood pressure normal for age, but again, blood pressure is a late sign of shock. You want the lactate and the base deficit to trend in the right direction. You want the mental state to the babies to be a little bit more alert, less agitated, less irritable. And urine output for me is one of the best markers to identify organ end perfusion. Okay, so you want to see a trend in the right direction. Okay, so just to go through the ABCs. So airway, be cautious of intubating these patients alone. Make sure you've got some additional help. And if you give a cardiac patient anesthesia, Try to use things like fentanyl, ketamine slowly, maybe even a dose of etomidate, especially for your patients with myocarditis, and give your drugs slower. Don't just yank these things in. Avoid things like midazolam and propofol and morphine in large doses, because that's going to drop your blood pressure. And in cardiac patients, especially myocarditis, expect decompensation. So have the adrenaline infusion running already and have the dose of adrenaline 1 in 10,000 ready to resuscitate them, because a lot of them can decompensate. So once your airway is clear and you think about their breathing, and especially if you've intubated them, expect pulmonary edema, especially in your left to right shunting patients, especially in your myocarditis and your valvular patients. They can have capillary leaks, they can have pulmonary hemorrhages and ARDS, so they can be quite difficult to ventilate initially, so they need some PEEP. But you want to limit their PIPs, so you want to maintain lung recruitment, so you want to have their pulmonary vascular resistance just at the right level. You don't want to over-distend or have atelectasis, because that's when they are going to struggle. Often these patients, like especially the small babies with PPHN or the patients with pulmonary edema, we will often use oscillation in them, but you want to try and maintain lung recruitment. Okay, so just a little bit on inotropes, and please tell me if I must stop and if you guys have something else to attend to, but just a little bit on the general approach of inotropes and how to choose the right inotrope for a child. And I don't think there's always a right or wrong, but I think it's choosing, looking at the specific lesion of the patient, looking at all the other comorbidities in your patient and all the other types of shock that's going on to choose your specific inotrope. But it's basically looking at vasopressors and inotropes specifically, and your main goal is you want to optimize oxygen delivery to the tissue. Okay, so again, we're looking at our equation of life and oxygen delivery. So just some definitions. If you think about inotrope, so what does an inotrope do? It forces, so it helps you with contractility specifically. Okay, so that is for the patient with myocardial dysfunction. You want to make sure that you have something like adrenaline that's got adequate inotropy. Okay, you want to make sure that your patient is in sinus rhythm. So you want to have good rate of contraction and you want to have adequate contraction. And then we talk about lucitropy. So something like milrinone gives you that myocardial relaxation so that you can actually fill well. So especially if you think about your stiff right ventricle, you want that heart to relax, to fill, and then to be able to pump. So that's thinking specifically at diastole. Okay. So just looking at different inotropes, what effect you're going to have. So we often talk about alpha, beta 1 and beta 2. Okay, so alpha is the constrictors. So they are the squeezers. Okay, so it's going to increase your systemic vascular resistance. So if you've got a myocarditis, you don't want a lot of alpha effect, because you don't want to make it harder for the heart to pump against increased systemic vascular resistance. Okay, so there you might not want a lot of alpha effect, but if you think about your tetralogy that's vasodilated and that's got a high fever, you actually want to squeeze them a bit to increase the SVR. So it's going to depend on what lesion you've got. So beta 1 effect is with thinking about that's what's going to increase your heart rate. And that's often one of the side effects that we see in adrenaline, that your patient becomes very tachycardic. And it's often not the shock, it's the inotropes driving that. So you need to be able to identify that. And then beta 2 giving you a little bit of peripheral vasodilatation. And yeah, I'm thinking specifically about dobutamine and adrenaline at low doses that will give you some beta 2 effect. So that's quite nice. That's something that we want again for someone with a myocarditis or a dilated cardiomyopathy. So a lot of alpha effect comes from noradrenaline, and like phenyl is a pure alpha or a vasoconstrictor. Adrenaline has got some alpha effect, and the higher dose of adrenaline you use, the more alpha effect you will get. Dopamine has got very little alpha, and dobutamine has got almost nothing. If you think about your beta-1, so that's what's going to make you so tachycardic. Adrenaline is often the big driver of tachycardia, and dopamine, especially in your neonates, dopamine can make them extremely tachycardic. Beta-2 effect, so adrenaline at low doses, and dobutamine has some beta-2 effect. And the nice thing about dobutamine and adrenaline, if you are cautious, you can run them peripherally. So don't delay inotropes because you think it always needs to be centrally. It can be given through intraosseous and it can be given peripherally, but controlled, watching the drips. As soon as you see any changes in the color of the arm, you obviously need to change that, and running low doses. Don't use high doses if you use peripherally. So if we talk about positive inotropy, we think about drugs like dobutamine, adrenaline, noradrenaline, even digoxin. If we talk about negative inotropy, things that's going to negatively impact the contractility and the function of the heart is often beta blockers. And that's why I said in that in tetralogy patient, and be very cautious in patients like myocarditis and dilated cardiomyopathies, do not use beta blockers on them, because that will definitely negatively impact their contractility. And that's why they often decompensate on intubation, because anesthetics and sedatives can often cause negative inotropy in these patients. So vasopressors. If you think about the squeezes, you can see that orange being squeezed. That's often your drugs that causes increased SVR. So it stimulates contraction specifically of smooth muscles in the capillaries and the arteries, causing vasoconstriction and increase in blood pressure. But it often doesn't improve your cardiac output. And if you increase the afterload significantly, that's often going to weaken your myocardium, especially in the patient that's already got myocardial dysfunction. You don't want to use high doses of a vasopressor, because you're going to make it very difficult for the left ventricle to pump across a high systemic vascular resistance. So often in patients that's got shock, refractory shock, that's when we will come in with vasopressors and noradrenaline. But for your patients with a weak myocardium, you need to be cautious. Okay, so just thinking again about low stroke volume. So stroke volume is related to preload and contractility, and then afterload. So the higher your afterload is, the worse your stroke volume is going to be. So thinking about the pump itself, and we think about decreased contractility and volume overloaded. Thinking about your tank, if they are hypovolemic in terms of preload, you want to fill them a little bit. And then thinking about pipes and your mismatch vascular resistance and stroke volume, you want to vasodilate them. So just looking at your lesions specifically is going to help you to decide what inotropes you want to use. Okay, this is just a nice picture of showing the different strengths of vasoconstrictors and drugs that's going to help with stroke volume. So your squeezes, your alpha effectors, specifically the weaker one is dobutamine with weak alpha effect, and your noradrenaline is your one with the best alpha effect. So depending on what you want, you either want to start off with dobutamine if you don't want a lot of vasoconstriction, but if you've got a tetralogy that you want to increase the SVR, you're rather going to go for noradrenaline. Then thinking about increasing stroke volume and what drugs are going to increase your heart rate more, there adrenaline is going to win, and dopamine is often like an adrenaline light, so like a Coke, you can get Coke light, it's like an adrenaline light, and then noradrenaline has got very little beta effect. So if you've already got a very tachycardic patient, noradrenaline is often nice to use. So these slides is just again going through the different alpha beta effects which we've spoken about. So now I just want to do the last case study, and the reason why I'm going to do this is we're seeing a lot of these patients, and I'm maybe going to ask Mary again if she wants to answer this, because I'm sure she's seen some of these patients with us, and I want you to be aware of this because I'm sure they're going to come through the emergency department in the next couple of months, and it's important for you to identify this type of cardiogenic shock. So it's a 7-year-old boy that presents. You can see an older child, 7-year-old, presents to the emergency department with very non-specific signs. So abdominal pain, fever, rash, and the heart rate is sitting at 114. It's got cold peripheries, a cap refill time of 4 seconds, a big liver. He's quite tachypneic. His SATs is sitting in the 80s, and his respiratory rate is at 40. So what will your differential diagnosis be? What questions do we need to ask? What workup are we going to do? And what's going to be your emergency treatment for this? So Mary, do you have a clue of what I'm talking about now?
Well, obviously you'll jump straight to PIMS, being what we're seeing now. So your multisystemic inflammatory syndromes, if you're seeing kids related to COVID. So but basically, I think we had a kid who looks like he's got a bit of cardiac failure, low SATs, abdominal pain. We're seeing quite a few of them. So basically, your history and stuff you want to find out. Well, the history, because it could be something else. There's a persistent fever. The conjunctivitis often looks a bit like Kawasaki's. But you want to find out COVID contacts, family history. Has anybody else been sick at home? That sort of thing. And then work through it and do a workup. You're obviously going to do a COVID swab, but you also want to get echoes, look at cardiac, you're going to look at renal, you're going to look at all your systems and look for your multi-systemic issues.
Okay, so in terms of workup, these patients often have very high inflammatory markers. So CRPs that's high, PCTs that's high, all of them have had incredibly high pro-BNPs, so about 30,000 often, or in the thousands. Their ferritins are often not like macrophage activation syndromes that's more than like 10,000, but they sit in the hundreds. A lot of these patients that we see, that's really a multi-organ involvement. So they present with a form of acute kidney injury. Their heart function is not, they don't have devastating cardiac dysfunction, but the function is a little bit off, like a myocarditis, sitting at ejection fractions of 30–40%. And some of them can have coronary dilatation as well, like a Kawasaki, like Mary said. So you want to, and a lot of them is actually quite confused as well. So they can really look sick and they can catch you out, these kids, because it's the older children. We've had a couple now that was that went to theatre as appendicitis, that had negative laparotomies. So the surgeons need to be aware of this condition. And their shock can be easily underestimated, because some of them will have normal blood pressures initially and just lactate that's going up a little bit tachycardic. So you need to identify them because they respond very well to treatment. So starting them on polygam and steroids normally brings down the inflammatory markers quite quickly. And although they are very sick initially, they respond quite quickly within 48 to 72 hours. Not all of them look exactly the same. We've had a couple of them that had more lung involvement than others, so quite severe ARDS. And then we've had a couple that ended up on peritoneal dialysis because their kidney injuries was quite severe. But all of them that's come through Red Cross, and we've now, I think, had about 35 in the last couple of months. So we've seen more PIMS, or multi-inflammatory MISIs, so multi-inflammatory syndromes in children, than we've actually seen COVID ARDSs at Red Cross specifically. All of them has survived, and most of them has gotten better quite quickly. So you need to be able to identify them, because if you don't identify the shock, I can easily see if you miss this, these children will end up dying because they are extremely sick initially. So I don't know if you've got any questions. 15 in the ICU in the last 2-3 months. And the difficult thing about them is some of them has got the history of COVID. So COVID a month or 2 months ago. Some of them just have the history that their parents had COVID and they were asymptomatic. But some of them actually don't have any history of COVID. So they'll maybe say they had a temperature a month ago. And in 75% of them, the COVID test is negative. So they're not shedding it anymore, but they've got this post-inflammatory syndrome. And I think in the next couple of months, we're still going to see quite a lot of that. And I'm sure a lot of you guys will now think about a patient that you've maybe seen that might have had this inflammatory syndrome, but was maybe misdiagnosed. So it's very important for us, and most of them get referred to Red Cross. And we've had a couple that had polygam, steroids, and tocilizumab to actually get them out of their inflammatory storm. So the rheumatologist is involved, the nephrologist is often involved. So it's a very multidisciplinary team approach to get these patients better. So go and have a look at the critical care website. I can also send it maybe to the organizers. There is a very nice algorithm out, a very nice protocol on the treatment and management and identification of these patients. But I won't recommend that you take them on alone, because they are actually quite tricky to manage. And I think for now, until we've got so much uncertainty, it needs to be managed as a team approach. We are starting to do antibodies on them for COVID, and I think we'll probably have that result out in the next couple of weeks as part of a bigger study to see whether the antibodies is positive. Okay, so I don't know if there's any questions. I see a few questions here. Are there any differentiators, importantly, that help, or we need to just remain suspicious in kids with this type? So for me, they are older children, so most of them is between 4 and 12 years old. So not very common that we see a small patient with PIMS, but that it can happen. I think the paper that just came out from the American description of PIMS, they've got something like 560 cases. Obviously, out of the 6 million cases of COVID they've got, it seems like a drop in the pool, but still 560 is very significant. They all have the history of fever. So if you look at this little one, fever, they have a rash, some abdominal mischief, and then most of them has got either cardiac involvement, renal involvement, and a lot of them almost present like an encephalopathy. They can be quite encephalopathic initially, especially with the shock history. So I will send out those guidelines on how to make the diagnosis. You can read through it. And the other thing that I would recommend doing early on is if their CRPs and their PCTs is like in the hundreds, you really need to consider the diagnosis, especially if it fits in with some of the clinical pictures. We have had a couple that we overdiagnosed. So we've seen a patient that had typhoid on blood culture, 48 hours, that had a bit of polygam because we thought he was a PIMS. So there's been some overdiagnosis as well, but I think a lot of them has been underdiagnosed. And it's very important that we need to pick up these patients, because if you don't treat, especially the Kawasaki type, and they've got coronary dilatation, they are going to end up with long-term problems, and they need to be followed up. So I don't know if that answers your question a little bit, Almira. So the markers we do, CRPs, PCTs, proBNP, ferritin, their D-dimers are often very, very high. And this is the one condition where we now, in kids, we don't normally start anticoagulation, but in these kids, we often start them on Clexane because they are very hypercoagulated. Okay. All right.
Can I ask you just briefly?
Yes.
So, at Karl Bremen Hospital where I am, we're obviously not a dedicated pediatric facility. Neither do we have a dedicated pediatric ICU. So yeah, we can't even begin to approach the kind of intuition and feeling and expertise that guys like you obviously have in something like this. So I'm always, when I'm confronted with a condition like this that presents like things that we see so often, and you kind of had that boogeyman effect. Oh my God, when should I consider this? What should I do about this? Now, your previous answer helps a lot, but I'm intrigued now if we're sort of saying that these kids, that we might be underdiagnosing them and that they actually require follow-up from the point of view of their coronary arteries and stuff. How's the pediatric sort of system currently thinking about doing that practically? Should we be incorporating more routine follow-ups or referrals for these kind of kids, or where does that leave, emergency practitioners practically?
Okay, so I think if you've got a patient like this in your emergency department, they are normally, if they are a severe PIMS, they are sick. Okay, it's not a type of patient that you're going to send home from the emergency department. a lot of the patients, because they present with very non-specific symptoms initially, they had 2 or 3 visits to the emergency department before they actually presented in extremis. Okay, so I think from an emergency department point of view, if you can pick it up on the first or second presentation, and often when patients, when that age group specifically keeps on coming back to your emergency department with fever, ongoing fever, a rash, think about this. And this is not the type of patient that should be sent home from the emergency department, rather should be admitted under the pediatric service, get your multidisciplinary team involved and do these investigations. And then long-term follow-up will be more in terms of your cardiac follow-up. So if they had initial coronary dilatation, they will definitely need echo follow-up. So what we've seen in these kids, especially the Kawasaki type PIMS, is they somehow recover very quickly. Their cardiac function recover very quickly once you treat them with polygam and steroids. So a lot of them has had their follow-up echo even before they left hospital, and they had normal coronaries. So I don't know if that answers your question. In terms of, I think for emergency department point of view, you need to have a very high index of suspicion so that you don't have the patient coming in and in again, and at the end present in extremis, rather catching them early in the inflammatory process than them coming in complete cardiogenic shock. Does that answer your question?
Yeah, no, that helps a lot. Thank you very much. I think that's a really good sort of actionable practical advice. Thanks.
Okay. Great. Is there any other questions? So just in summary, if we now think about cardiogenic shock in general in children, we want to think about our goal for treatment, and that's basically restoring oxygen delivery. And that's looking at our cardiac output and our oxygen content. And then assessment of our patients. We want to, at the end of the resuscitation, have a conscious child, good skin perfusion, good urine output. You can look at your trends on your central venous sats and your lactates just to help you. But I think those are normally good markers to see whether your patient is moving in the right direction. Okay. And think about all the different things what that can potentially be wrong with your patient. So there's obviously a very long list of different things that can cause cardiogenic shock. But in children, if you've got a good approach in terms of your congenital heart conditions, myocarditis, and just a general good approach on your ABCDEs, then I think you will do a fantastic job in stabilizing them and getting them to a facility that can actually manage their cardiogenic shock. Okay. Any questions? I don't know if there was anything that maybe didn't make sense, or any of the case studies that you've got some questions about.
Martie, there's just a question on the chat section.
Okay, can I ask a question about hemorrhagic shock? Yes, definitely.
Hi, Martie. Thank you so much. I mean, this is a fantastic talk, and I will be listening to this again. I just got a question, and I know it's why we have you here. I thought I might as well please ask you so you can give me some advice. So this is specifically also a case that I've seen. It was a young child or a young teenager, so say I think it was 14 or 13, but had a gunshot to the abdomen, presented to a trauma unit, came in with this immense sort of compensatory shock. So he was peripherally cold, mottled, very vasoconstricted, and had a blood pressure of like 190. So he was mentating, GCS was 15, but the issue is now we know he's got, fast, obviously he's peritonitic, he's got a lot of blood in his abdomen, there's a delay to theater. So now to try and balance the principles of sort of a hemostatic type resuscitation versus for a fact that he needs blood, but you don't want to give him too much to push over and decrease his own compensatory mechanism. I mean, from my reading around specifically this type of case of, not in children though, but there's talk of using sympatholytics like fentanyl and sort of titrating between breaking that sympathetic response, but also replenishing the blood volume to try and get you to theater. Is there any other thing that we should, in this specific sort of severely compensated hypertensive type shock patients, that we should know to?
Yes, definitely. So I'm busy opening the APLS massive hemorrhage protocol, because that's basically what you need. For this patient, you would definitely need blood. Okay, so in the APLS kind of scenario, we even say you will maybe give 5 to 10 ml per kg of warm fluids just while you wait for the blood, because you know what the issue is. You need source control and you need blood, okay? We very early on give them tranexamic acid, but you're completely right. You almost want to allow a little bit of permissive hypotension in them, because you don't want high blood pressures that they just lodge the only clot that they are busy forming, okay? So in these patients, specifically with intra-abdominal bleeding, and also the patient that come in with femur fractures, they can be so sick and shocked and needing a lot of products. So I think getting your surgeon on board is definitely what you need. You need to get tranexamic acid in very early resuscitation with warm fluid, but that's basically just while you wait for your blood products. So what we normally say in terms of blood resuscitation, you will give 5 ml per kg of warmed blood, and then early on you need to think of correcting them with other blood products. So get your platelets in, get cryo in for them, FFPs. So as soon as you get to 20 ml per kg of blood products, you need to start replacing one-on-one with FFPs, and then consider giving things like calcium, replacing that, thinking about your factor 7 if you still, your Nova 7 if you're still not getting control. But this is basically a nice algorithm to follow in terms of massive hemorrhage, but again allowing a bit of permissive hypotension. So inotropes, you can start them on a little bit of adrenaline, but you don't want their blood pressures to be more than, especially if you're talking about teenagers, you want their mean blood pressures around about 65 for organ perfusion. You don't want blood pressures means of 80, 100, because then you're going to dislodge your clot. I don't know if this answers your question.
Yeah, I think it's most of there. My concern was that so with this particular patient, his initial presenting blood pressure is 180 systolic. After the first so he had a little bit of analgesia, and then after the first fluid bolus waiting for blood, his blood pressure goes to 210, 215.
Okay. So I think in a trauma setting, we are often too scared of analgesia, okay? So this is the type of patient that definitely needs to be run on a fentanyl or a morphine infusion. If you are worried about massive hemorrhage, then often, and you've got access to fentanyl, then fentanyl above morphine, but you definitely need to run them on some opioids, and then giving Perfalgan early for them, so 15 milligrams per kg of Perfalgan would also help them with pain, especially if they are that hypertensive. So a little bit of a bolus initially of their fentanyl, and then run them on an infusion of about 2 mics per kg per hour, or 20 mics of morphine per kg per hour. Does that answer your question?
Yeah, that does. Thank you.
And sometimes even if they are in excruciating pain, again, a little bit of ketamine, 0.5 per kg, just to get acute control, so that they don't jump off the bed and actually make themselves worse in terms of dislodging clots. You can also try that, especially with ketamine. It maintains your systemic vascular resistance quite well, so they don't drop their blood pressures that badly.